All right, guys, we're just going to continue on with some airway management, ventilator management stuff, oxygenation, ventilation. So just want to talk about when we pull the trigger on intubation, and really intubation, there's only a couple of criteria that we should be looking at intubating the patient. And typically, the first question is, when do I intubate? And there's usually three specific reasons that I would intubate a patient. Again, it changes. Every provider is a little bit different. But basically what you need to remember is this, is that every airway is a failed airway, okay, until it isn't. That means that every airway, okay, is going to fail until it doesn't fail any longer. If you take the ability of that patient to protect their own airway away from them with paralytics, you are responsible for the airway, because now it's a failed airway until you're able to secure it. So we should not just be intubating patients. Not that I suggest that anybody's intubating a patient electively, because I don't really think that that's happening. But it's something that we really need to be careful with. And I don't want it to come across insulting, because it's not intended that way. But these patients that we are taking care of that come in with COVID, with trauma, teeth in the airway, vomitus in the airway, blood in the airway, they have not been MPO for the past 12 to 18 hours. They're not on a white sheet. They're not, able to be positioned ideally in many cases. So, that's not a knock on anesthesia. Man, those guys manage airways, like nobody's business. I mean, that is their primary career path. And getting the difficult airway is their specialty. Okay, so but the difference is that they do a lot of controlled airways, and they get a lot of exposure, where we as in EMS and in the emergency rooms, we just don't see the number, the sheer volume that they do. So it becomes a problem if we don't keep those skills up. So we should have adjuncts ready. We should have everything ready to go before we actually pull the trigger. So the 3 times that I look at, okay, when I need to pull the trigger on intubating somebody, is if they've got an altered mental status. So if this patient, we used to say that Glasgow coma scale of 8, right? So we know that you get a 4, 5, 6, and basically that's for the eyes, that's for the verbal response, and that's for motor movement. And if it adds up to less than 8, we used to say Glasgow of 8, intubate. Well, honestly, if somebody's not able to protect their airway, if they're not able to manage secretions, if they're not alert enough to maintain an airway, if they're able to accept an oral airway, an OPA, that's a patient that I'm going to pull the trigger on and I'm going to intubate. Okay. The second patient that I look at is the patient that we look at the expected course of treatment. So when I've got a patient that comes in and they're breathing 25 times a minute, and they're doing let's say 400. That's pretty easy to see that they're at 10 liters per minute on the minute ventilation. Okay, they're doing a lot of work. Okay, so when I'm looking at somebody that needs to rest, okay, I can take away 30% of their metabolic demand by resting them, by putting them on a ventilator. And if they're septic, they're able to take that extra 30% and put it towards healing. They're able to improve more quickly. They're able to recruit that muscle more quickly so that they can get that diaphragm moving again. The one where we kind of have issues is this, okay? So when we talk about respiratory failure, okay, easy if they're in respiratory arrest. You pull the trigger, okay? You intubate them, okay? But respiratory failure is 2 different animals. And this is one of the things that I think is jamming us up. And we need to consider, is this a patient that definitely needs to be intubated early on, or are we doing enough in the way of adjunctive therapies? So there's 2 types of failure, okay? One failure is you can have CO2 that's too high. That's sometimes okay. When we talk about a high CO2 that we're allowing it to run like 70, 80, that type of thing, like in a COPD, or sometimes we do that, that's called permissive hypercapnia. I'm okay with allowing that if the patient's still breathing, because they have a different drive. Okay? For you and I, when our CO2 goes up to 70 or 80, we're in trouble. If our CO2 breaches 50, basically what happens is the the medulla oblongata sends out neurotransmitters, and it basically tickles your intercostal muscles and it tickles your diaphragm, and it says, hey, take a breath. We need to get rid of this. We need to blow this down. And that's how we drive. We're a hypercapnic drive. The COPD, or the reason why we keep a COPD at 88 to 92%, right, is because they're all the way up here at 100 on the SpO2. I'm sorry, 100 on the CO2, and they're not taking a breath. Why? Because they function on a hypoxic drive. They function when this number drops, they take a breath. That's why we're not supposed to put COPDers on 100% oxygen, okay? If they need it, they need it. We can intubate them and that type of thing if we need to. But the key is that we don't routinely give high concentrated oxygen to COPDers because it knocks out their hypoxic drive, okay? So I'm okay with some of these patients that have a high CO2. They have a hypercapnic respiratory failure, okay? Kind of the same concept behind, well, I'm okay with patients that have a low blood pressure if they're bleeding somewhere inside, right, trauma, because I don't want to tank them full of fluid. So I'm okay with permissive hypotension. Same type of thing as permissive hypercapnia. The issue here is, right, when you've got the SpO2 that's low and you've got a patient that's hypoxic and they have a hypoxic respiratory failure. Well, it's not okay to have permissive hypoxia, okay? So you need oxygen. We said at the very beginning, you need oxygen to get to that cell, okay? And in order to get to that cell, it has to have a decent enough blood pressure and it has to have enough FiO2 and enough PEEP to get there, okay? So if you find that you've got your FiO2 at 100%, you've got your PEEP at 5 to 7, you've gone to high flow nasal cannula, and your patient is still having trouble, and you're looking at a patient that is failing, either not able to protect their airway, becomes unresponsive, or if that SpO2 is just reluctant to move at all, and the patient's unable to position themselves effectively anymore, then that's probably time to pull the trigger, and it's probably time to put the patient on a vent and start looking at how we can support them. So your goal with the ventilator is going to be improving oxygenation, especially in these COVID patients, improving ventilation, not so much in these COVID patients. And then you really need to consider in the back of your mind, do we really need a ventilator, or is this adjunctive therapy going to suffice for now? So thanks for your time. I appreciate it.